So when I came in this morning, I've already been asked by a few people why this topic, by multiple people separately, not hearing other people. There's a number of reasons. Initially, it started with a case that I saw in pre-admission clinic about a month ago, and the patient obviously had a mitochondrial disease, and I hadn't even heard of the particular name of the disease, and I thought, well, maybe I need to know more about this. It also triggered a memory from a recent registrar M&M where Charlie presented a patient that he had, I think, an endoscopy with MELAS. Again, I was thinking, well, I need to know more about this. And also, as a fair number of you know, I'm going to do a PEDS fellowship next year, and I thought, well, this is going to come up a bit more and I should probably know a little more about it. So an overview of my talk. Initially, I'm going to talk about the case that motivated me to talk on this topic. Then I'll go through the mitochondrial structure and function for Murray, who loves mitochondria, as he admitted. And then run through briefly, because I certainly got bogged down in a lot of this mitochondrial diseases, and then going on to the anaesthetic implications. What evidence is there, and are there any recommendations for anaesthesia for these patients? So it was a Tuesday afternoon in pre-admission clinic, and I'd sort of seen all the patients. I thought, just one to go. Picked up this chart, and they said, she's in the room. And straight away I thought, that's not a good sign that they're waiting in the room. And I sort of had a quick look through the chart, and the history was a 43-year-old lady. She was booked for a marginal resection of her left mandible and removal of a couple of teeth on that side. The indication for the surgery was written as chronic osteomyelitis in that left mandible. And on the RFA, what was written down was a background. I put question mark, because I hadn't heard of it at the time. I probably should have. But of KEARNS-SAYRE, I think that's how you say it, syndrome. And already my heart had kind of sunk. And I think whoever I was on with, I said, you go, I'll see the last one. And so I walked into the room, and I saw a middle-aged lady sitting in a wheelchair. She had a beanie on her head, dark glasses on. She had massive woolen socks. She was very cachectic looking, and I thought, okay, what is this? I had some observations that the nurses had done when they'd seen her before. They were mostly unremarkable, and as of note, on her height and weight, she was quite cachectic, and I also noticed that she had a very high blood sugar. So on talking to her, and then also later getting records from a neurologist that she saw, I sort of built together a background of her illness, because she was, in some ways, knew a lot about it, but then in other ways was very vague and dismissive about things. So she first presented in 2004, and she hadn't told me this bit, but she presented to the neurologist with a 10-year history of intermittent bilateral ptosis, and also her major issue was painful peripheral neuropathy that she had mainly in her feet, but it was also in her hands. Basically, as a summary of what the neurologist looked at, I think initially he was thinking myasthenia gravis, maybe two separate things with the peripheral neuropathy. He did a lot of testing, and this was over a couple of years that this occurred, and she had progression of her disease in that time. But initially it was just those first two things she presented with. So he did tensilon testing, all the things listed there, the ACH receptor, looked at her TSH. He also did some DNA testing for mitochondrial mutations, but it didn't come up with anything. And during this time, I think it was over a period of 2004 to 2007, her disease progressed, and she started to develop significant limb weakness in both her upper and lower limbs, and also a divergent squint that she didn't have initially. She just had the ptosis. In the summary of him seeing her, which the final time was 2007, he felt that it was likely a mitochondrial disease, but he actually didn't give a diagnosis of what mitochondrial disease he felt it was, which seems like it's not unusual that these patients don't fit into a particular pattern, which she doesn't, even though she's convinced she's got this diagnosis. And he also he diagnosed her with diabetes, put her on some medications, and felt that the peripheral neuropathy was a separate thing related to her diabetes, which is actually related to her mitochondrial disease. She told me, and she didn't know the name, so I couldn't find or contact the ophthalmologist, that the ophthalmologist actually diagnosed this KEARNS-SAYRE syndrome, that he saw pathognomonic things in her eyes when he had a look and was convinced that's what it was. This is her hearsay. and I said, so who are you seeing now about your disease? I was trying to get an idea in the clinic who to talk to about her. And she said, look, I'm not seeing anyone. No one seems to know about this really. And I was thinking, including me. And that she'd last seen the neurologist in 2007. But she was also able to tell me, I had surgery in 2008 at Liverpool. I had a cholecystectomy. There were no problems at all. And I thought, right, I'll try and get those notes. And I also got information on her medications, which her cardiologist, who she'd continued to see, had put her on. She was on propranolol, Cavasil, diamicron, and also oral amoxicillin for this chronic infection. So the recent history, which one of the investigations mainly highlighted to me, was that she had quite a significant deterioration in her condition, and when I sort of took a history, it seemed like it aligned actually with this illness of this chronic osteomyelitis. And in the maxillofacial report, they actually talked about frank pus. It sounded like she was very unwell with this infection, but she'd had loss of appetite in that time. She reported some difficulty in swallowing that she said was new, that she'd had significant weight loss in that time because she wasn't able to eat, and that her weakness was a lot worse, and hence she was in the wheelchair in the pre-admission clinic. So she said she was walking around the house with a stick, but using the wheelchair outside the house. So I, in the process of thinking about further things I was going to do, ordered some investigations. So bloods-wise, as you can see, she was slightly hyponatremic. Her LFTs were abnormal. They were actually, there were some from July, and they were improved from then. She had low magnesium. I noticed her white cell count wasn't raised as well. It was only 8.2, which I was surprised at. Her coagulation was normal, and her HbA1c was 8.6. She also had an ECG in her notes at the time that I sort of briefly looked at, and then when I read up on her condition, looked at again. But there was nothing of note on the ECG, particularly significant, as I'll outline to the condition. In some of her paperwork that she had a letter from her cardiologist that went through some investigations that she'd had in January last year. She'd had a transthoracic echo done then. She had which was essentially normal function, no valvular disease. And then what I noticed, and this was exclamation marks at the end, they talked about an exercise stress test. And I thought, this is a woman sitting in front of me in a wheelchair. She's, reached 88% of her predicted heart rate. And that's when I sort of went back and took that history to find out when this significant deterioration had occurred. But it did sound like it was related to her current illness, but I couldn't be sure. So from here I thought, right, what's the plan with this lady? I thought, in her letter from her cardiologist, he had wanted to see her again in a year, so that would have been January this year. She hadn't, which seemed to be a recurring theme with this lady, that she, despite the impact of her illness on her life, she didn't seem to follow up with appointments. So I referred her to the cardiologist. There was about 5 weeks between when I saw her and surgery, which is booked for tomorrow. And I was able to get her in for an appointment for the cardiologist, and when I phoned her earlier this week, she'd actually missed that appointment and then got a late. She said it was her eyesight. She read the date wrong, but she actually did end up seeing the cardiologist on Monday this week. I thought I need to chase up the anaesthetic records from Liverpool to get an idea. That was 2008, and also speak to the anaesthetist that was doing the list and discuss her. So when I got before I spoke to the anaesthetist, I was able to get the results from Liverpool of the anaesthetic chart. I didn't get the chart from 1996. I'm not sure whether that was in Liverpool, but they commented on the chart of the cholecystectomy that she'd had a caesarean in 1996. It was a pre-diagnosis, obviously, and she'd had a GA with saximethonium used then, and they said no problems. She had a cholecystectomy done in 2008. Everything seemed reasonably standard with the anaesthetic that she had then. The only comment down the bottom, and they'd certainly taken a history of her illness on the front, was that they had used external pacing pads intraoperatively and that there were no problems. And I haven't scanned it in, but her observations during the case didn't show anything remarkable. She was a bit hypertensive initially. I think this was probably before the cardiologist had adjusted some of her medications, but things seemed reasonably smooth on induction and emergence, and she didn't go anywhere fancy afterwards. So just diverging now to talk about mitochondrial structure and function, this fascinating organelle. So this picture got, I don't know why, I think changing my PowerPoint, some of my pictures got cut off a little bit, but this is just showing a schematic diagram on the outside and then the electron microscopy, and showing some of the functions on the side there. So as we all know, going back to primary exam and university biology, so it's a double membraned organelle. So you've got the outer membrane, then the inner membrane with the cristae on it, increasing the surface area, and you've got the matrix inside that inner membrane, and then the intermembrane space between the two. And along the side of the functions, so of note are the electron transport chain with oxidative phosphorylation, which occurs across that inner membrane, linked to movement of hydrogen, and also the citric acid cycle that happens within the matrix. So this is just running through that it's double membrane. I've said that it's in all cells except red blood cells, and they're in varying numbers depending on the metabolic activity of the particular cell. And this function that I was talking about is the generation of the ATP via this aerobic metabolism. So it's basically using the reductive equivalents from other pathways such as the citric acid cycle, and then oxidising them and linking it to hydrogen is much more complex than this obviously, but linking them to hydrogen transport and creating this ATP, and then just talking about the other pathways down the bottom. So something unique to mitochondria is that they contain several copies of double-stranded DNA, so it's actually mitochondrial DNA that is maternally inherited. And this gives them the ability to manufacture their own mRNA and proteins. However, most of the mitochondrial proteins are actually encoded by nuclear DNA, and I'll refer to this later, the genetics of that are standard with the autosomal recessive dominant X-linked. So going on to mitochondrial diseases, and this is where it took me a long time to get any sort of grasp on this. I just saw huge lists of names and symptoms. It's very much a multi-system disease, and also definitions. I got bogged down a little bit. Initially I was thinking about mitochondrial myopathies and then realised that's only one subset that is quite unusual to just be isolated myopathies. It's usually multi-system, and even if a patient hasn't got symptoms of a myopathy, often on muscle biopsy you will see the pathognomonic abnormalities. So it's a group of diseases related specifically to impairment of this respiratory chain, which is involved in the ATP production. Big range of incidents reported. The figures that I could find were between 1 in 4,000 and 1 in 15,000, which I thought 1 in 4,000 seemed very high. But there was they talked a lot about maybe underreporting, and that's where that range came in. They often present in childhood, and that's related to what I was saying. I'll probably see a lot more of it and a lot more severe cases over at the children's, but there is a significant number like this lady and like the case that Charlie talked about at Registrar M&M that do present in adulthood. And I saw quoted a few times that it's considered the most common myopathy of adulthood, or myopathies. So going back to that genetics and related to the unique properties of mitochondria, that they sort of group it into, very hard to find a classification, but they group the cause of it into 3 different groups: the inherited mutations of the mitochondrial, the nuclear DNA, which is the vast majority, and then spontaneous mutations as well, or deletions. There's greater than 100 conditions described. The 2 most common that people probably have heard of at least are the MILAS, which is the mitochondrial encephalopathy, lactic acidosis and stroke-like syndrome, and also Leigh syndrome, which is a subacute necrotizing encephalomyelopathy, which from what I read is quite a severe mitochondrial disease. So there doesn't appear to be any clear correlation between the clinical findings and the site of the biochemical defect. And everywhere they talk about, which I guess isn't unusual, but phenotypic heterogeneity, and that there's a complex relationship between the genotype and phenotype, and also what makes sense that the percentage of mutation load is going to affect the severity of the disease. So just going back to the case that I talked about and what diagnosis this lady told me that she had. So to fit into this syndrome, you need a triad of clinical findings, which are said to be an onset less than 20 years, and if her history was right, and it's hard to know how long she had the symptoms. She didn't actually, it would have been in her late 20s, maybe she started getting this ptosis, that they get chronic progressive external ophthalmoplegia, which she certainly had, and from what she was saying from the ophthalmologist, that she probably had this pigmentary retinopathy. So have those three plus one more of this complete heart block, which is the serious thing that we certainly worry about with anaesthetics. I had no information on whether she'd had CSF protein done, and also she certainly didn't seem to have cerebral ataxia. And this is just a diagram illustrating the external ophthalmoplegia, the patient with ptosis, and the symbols on the right-hand side show, obviously the first one's neutral position and show the patient attempting to move their eyes in the different directions. And certainly after, and I realised why she was wearing the dark glasses, was that she had when she took her glasses off to show me, and she had very marked ptosis and did have a divergent squint, and I presume that's why she wore the glasses, so people didn't stare. Other things are that as she developed, that they get progressive limb muscle weakness and easy fatigability, and that there's a strong association with endocrine disorders, which she had diabetes. I think they quote the figures as something like 13% have diabetes. There's thyroid disease and other things. And also can be, and I presume this would be more severe cases than hers, mental retardation and dementia, neither of which she appeared to have. And then just with the cardiac conduction abnormalities that they talk about a lot in this condition, 20% of the deaths are due to this complete heart block, which obviously the anaesthetist alluded to, talking about the external pacing pads in the cholecystectomy that she had. But looking back at her ECG, she had no signs of heart block at all on that ECG, but I still felt she needed to see her cardiologist again and check everything was okay. And the genetics of KEARNS-SAYRE is that it's a sporadic, non-inherited disorder. And in the neurologist notes, they noted that, so she'd had a daughter via the cesarean that I talked about before, that there were no problems with the daughter. Also, she had a brother that there were no issues with, and both of her parents, there were no issues. So going to mitochondrial diseases in general, related to the diagnosis, as you probably figured, it's not that straightforward. There's no clear clinical pattern, which isn't unusual, that you might see that suggests that there's a mitochondrial myopathy, but they say you need to have a high clinical suspicion and to be suspicious of it in progressive diseases that are often multi-organ diseases that you can't really explain why this might be happening. There is DNA PCR for some of the mutations, but as in this patient, the neurologist didn't pick anything up on the tests that they had. Another thing that seems to be quite common is the persistent hyperlactemia that they talk about in plasma and CSF. Brain MRIs are also used a lot, and I think that's only in some conditions that they have characteristic lytic lesions. And then something that this woman actually hasn't had, which was advised for her to have, is the muscle biopsy that has a very classic appearance called ragged red fibres. And when I asked her, I don't think I realised at the time at the clinic that she hadn't actually had this done. I just presumed she had to be able to get this diagnosis, but she said, I hear it's very painful, I've sort of put it off. And this was back in, I think, 2005 that it was advised that she should have it done. And when I spoke to her early in the week, she said, yeah, they did say maybe I should have it done on Friday as well as the jaw. And I thought, well, it's not quite that simple. So this is an illustration of those ragged red fibres, and it's related to, in the myofibrils, that there's proliferation of the mitochondria and abnormal mitochondria at some specific stain that shows up in this dramatic way, and that's a closer image of it. And they do talk about, I won't talk about that yet, it's anesthetic, that there are different techniques that can affect the diagnosis on the muscle biopsy, but I'll go into that now. So anesthetic implications. This was something that sort of, when I went through doing the searches, there didn't seem to be a lot of information on this, which I was and wasn't surprised about. That there seemed to be a lot of interest in mitochondrial diseases back in the 1980s, and there were a lot of papers published then, and then there seemed to be a reasonable hiatus, and then there's a few sort of papers published maybe 2004 to 2008 that are kind of summaries which say this has been published as a guide to the anaesthetist to give them some idea what might be a recommendation for conducting anaesthesia in these patients, but all of them were very non-conclusive. So some of the questions that were raised or that I had were, are patients with mitochondrial disease sensitive to anaesthesia? There's a lot of mention of, it was mostly in vitro studies, but studies related to, and it said at supraclinical doses of volatile anaesthetics uncoupling the oxidative phosphorylation, and it would make sense in these patients that they would be more sensitive, but that was supraclinical. Is there an association between mitochondrial disease and malignant hypothermia? I printed out some of the older articles, and there was a reasonable amount of mention about it then, and saying, you know, maybe succinylmethonium should be avoided related to that. But in the latest papers, quite strongly, they don't say there's absolutely no chance there is a link, but they say it is, this is something like it is highly likely, there is no evidence that there is a link between the two. And certainly in some of there's lots of a couple of retrospective studies that go back through what anaesthetics these patients had, and the majority of them had volatile anaesthetics. And also another issue is muscle relaxants, what are safe and what dosing do you use? And just that final kind of wrapping together, is there sufficient evidence to support a recommended technique? And really there doesn't appear to be. So just running through the different phases of planning your anaesthetic. So comments that were made about pre-medication and fasting is in these patients to avoid excessive fasting, and this will, I guess, particularly be an issue in children, that the stress can worsen this lactic acidosis that they often have. They also talked about a risk of hypoglycemia, but this was in patients with hepatic dysfunction. They talked about giving dextrose-containing fluids and also obviously avoiding lactate-containing fluids. They talked about this defect in the respiratory control in these patients that they think is a central effect rather than something mechanical, and saying that, you know, if you're to use something with respiratory depression, this is going to be at any phase, to use it with caution or to avoid it. Then for induction, some of the articles I tried to download and couldn't because they were quite old. They talk about, a lot of the time it says there is this theoretical or this potential increased sensitivity to induction agents, and they said it's particularly, and this was back in the 80s, been shown to thiopentone. But in other places that say, you know, all of these have been used safely, we recommend using them cautiously, whatever that means. And then in relation to inhalationals, certainly a lot of the studies were involved in anaesthetising children, and they had inhalational inductions, and they talked about caution with halothane, which isn't going to be that relevant now, but that certainly gets rid of the idea of this malignant hypothermia. So in relation to muscle relaxants, there are a couple of studies that said, yes, there is an increased sensitivity to non-depolarising muscle blockers, but then there was other studies that said, no, we've shown normal response, and they said, well, like any other patients, there's going to be a variable response amongst individuals. But they certainly recommended to use medium duration neuromuscular blockers, to use them judiciously, and obviously to use neuromuscular monitoring for these patients. And when I saw this patient, I spoke to Mark about it from the clinic, and he certainly said, you know, if possible, which it would be in this procedure, to avoid muscle relaxants if you don't need them, which seems to me to make sense. And then also it was recommended to use atracurium or cisatracurium related to renal and hepatic dysfunction, which is quite common in these patients. And then, I've spelled it wrong there, succinylmethonium. There was some, and I really struggled to find someone to give, you know, a hard answer on this in any of the papers, was about succinylmethonium. It seemed like people generally just avoided its use back in the older papers related to the malignant hypothermia risk, but then also that there was some theoretical risk of hyperkalemia in these patients. So with maintenance, all the titles, sorry, messed up, and I've just made TANS. When I changed it to PowerPoint, I had to change them. So there's been a change in opinion earlier on in these old articles. So there's sort of the two groups, on older articles, newer ones. They talked about that TIVA is a recommended technique for these patients, and then it changed quite markedly with the whole advent of this propofol infusion syndrome. and now they say we highly recommend to avoid, even in short duration, to avoid TIVA, that there was some reports of delayed recovery and ICU admission. And I mean, it seems to make sense that these patients may be at high risk of this propofol infusion syndrome, in that, you know, it's involved in impairment of the free fatty acid utilisation and the mitochondrial activity. And there was one article that said, talked about children getting this infusion, that it was felt that maybe some of these had actually undiagnosed mitochondrial disease or a very mild form of it, and that was what put them at increased risk. But obviously, as we know, there's the other risks of acute sepsis and drugs used like catecholamines and steroids used in the ICU. So then going on to analgesia, again, what seems to make sense is related to this impaired respiratory control, that you use opioids cautiously. A lot of it just seems to be sensible advice that I found, really, to use opioids with caution, to use multimodal analgesia, but again, you've got to have caution with non-steroidals and paracetamol with the hepatic and renal dysfunction, and just talking about the benefit, like pre-operatively, decreasing the stress, so managing their analgesia well to avoid these exacerbations of acidosis, and then keeping in mind with regional anaesthetics that not only hepatic dysfunction causing coagulopathy, that some of these patients have thrombocytopenia as well with this multi-system disease. So going back to the patient that's booked for anaesthetic tomorrow, so she had a cardiology review, as I said. There were no new concerns. That this was just a verbal report from the cardiologist. I think Jill from the clinic had phoned, that he'd done a repeat echo. There was nothing. He'd stopped her Cavasol because her blood pressure was, I think it was 103 or something systolic when she was in clinic. He kept her on the other medications. I mean, the issue here is that it sounds like she's become quite unwell with this illness, and that it is a chronic infection and that she needs something done about it. We booked an ICU bed for her, and the plan would be to talk to the surgeons about, they're already aware of her, but to talk to her about use of local anaesthetic so we can limit our analgesia. And certainly in this case, as I said earlier, it would be reasonably easy to avoid muscle relaxation. They're going to want a nasal tube that we can spray the cords, and that I think it's Robin doing the case, I think is who I spoke to about it, that would probably use external pacing pads, and obviously careful titration. Don't know whether that's changed. Careful titration of the drugs that we're going to use, and monitoring wise, certainly using neuromuscular monitoring, whether we'd use entropy. None of this increased sensitivity on entropy studies seem to be founded, and certainly with the invasive blood pressure, they talk about doing, that'll allow us to monitor lactate. I'm not sure how long the surgery is going to take, but sometime having a look at a baseline at the start and then monitoring her during the case. And these were the references that I was sort of saying there was a gap. There's some older ones as well, and I used up to date just to get background sort of information on it.
Thank you. I knew there had to be a reason for Robin being here so early. Have you got any questions, Robin? That's up to you. Does anyone else have any questions or comments? Where's the photo from?
The Picos de Europa in north of Spain.
It would be good if you did do this case tomorrow when you wrote the case up.
Yeah.
Your approach, fascinating presentation, but I think it would be right. You've got to write this up very, very well, and inhalation induction sounds a good idea. I might limit the amount of bupivacaine you use because in high doses, we're studying about 1 kilogram or something.
Yep.
That actually inhibits oxidative phosphorylation.
And there was mention of that, yeah. Yeah, they definitely talked about that, but then, they talked about, that there has been, again, in vitro evidence of uncoupling of oxidative phosphorylation, but just caution with, everything was just caution with the dose of your local anaesthetic.
I was wondering about her respiratory function.
Oh yeah, that was the other thing that I forgot to put in here. She had, so in in 2008, the other thing that the anaesthetist wrote as well was bedside FVC good, tick, that they'd done, and she had spirometry as well done that I forgot to put in her. Seemed a bit strange, the figures didn't fit. Her FEV1 was only 1 and her FVC was 24, so that was 30% of predicted or something, the FEV1, but the FVC was 63%, and I wondered whether she maybe didn't, you know, I wasn't there when she did it, but certainly was worse than before.
Another comment, this is a theoretical comment, looking at the study's energy supply and weakness and stuff, we're really interested to see whether she responded to creatine phosphate exogenously. As you know, skeletal muscle sort of ATP gives you instantaneous energy, but actually creatine phosphate as a source of energy is about 4 to 5 times, and you actually get more energy out of a mole of creatine phosphate, sort of 10,000 kilojoules as opposed to only about 7 from 1 mole of ATP. So it'd be interesting to see if this lady had a course of creatine tablets, whether or not that would improve some of her muscle weakness, recognising how it works pathophysiologically and what's actually wrong with it.
I know when I looked at treatment, I didn't go into it, but treatment of a lot of them and KEARNS-SAYRE as well, they said nothing, they hadn't found anything that was effective. There's talk of coenzyme Q10 and things like that, but they had found nothing that was effective other than treating the problems that you get with it, but nothing for the weakness specifically. But yeah.
Interesting research thing to do, actually.
Mark.
Yeah, no, it's a good presentation, thanks for that. But basically, down at this hospital, I think you find if you talk to people about what they do, it's pretty nebulous to pin down what you do with mitochondria, because they're all different and half the time you have a name that you've not heard of before,
Yep.
as you know what you're talking about. So I think getting them in and getting well hydrated at the start and avoiding sort of metabolic stresses before the procedure. And then most people just try and avoid muscle relaxants. If they use them really
Small, okay, yeah.
most people, because it genuinely involves a myopathy of some description, they avoid sucks just
Just
because of
in case, yeah.
myopathy, not because of any specific thing related to mitochondrial myopathy. And then you treat them symptomatically, so if they're respiratory quicker from the start, you talk about ICU or you keep them ventilated and see how
Yep.
you go. But it's nothing specifically different that we do about mitochondrial myopathies per se.
To other ones.
Sort of avoid those fasting issues, and often you ring up the clever doctors, the pediatricians will say, what is it specifically
Yeah.
you have concerns about this, which you're lucky enough to do, and then you can ask them specifically about this syndrome, what is it. But in general, it's very hard to pin down exactly what you do.
Well, there were a few retrospective studies done where they look back at, one of them I think was 122 cases and one was maybe 38 patients with 58 anaesthetics, and they look back and there was just everything done pretty much for them and didn't seem to be any specific anaesthetic that went, oh, there was an increased risk with that one.
I think the only new thing is the issue with
Yeah. Yeah, with that, and it makes sense.
Any questions, Jon? Well, thanks very much for coming.